So I'm happy that I'm here because you missed the meeting in Venice and Las Vegas, so I have to fill in.
You do?
You know, there's a gap of knowledge now. And Dr. Caliph is a good friend of mine, and I'm not going to want to mess with him. So we have to basically... So this is not a congenital disease, but it's really a condition that everybody who deals with pregnant women has to be familiar with. One of the phenomena of this condition is that people don't diagnose it on time. The awareness of this disease is, for some reason, very low. I'll start here with an example that represents some of the important aspects of this condition. It's a young woman, African American, had an uncomplicated C-section at 33 weeks because of preeclampsia. So remember preeclampsia, very important component of that. Readmitted 3 days after the discharge, and this is not for heart failure necessarily. She had abdominal pain and had surgical evacuation of abdominal wall hematoma. And then she went home in what they define as stable condition. The heart rate was 115, 120. She had some anemia, attributed to anemia. The EKG was not normal. The T-wave inversions were not normal, but the EKG was actually ignored. She went home, and 4 days post-discharge, she was found without vital signs at home and was pronounced dead. And the autopsy confirmed that she had a cardiomyopathy. So again, the patient, African American, you'll see that preeclampsia, and the fact that people actually think about almost everything but peripartum cardiomyopathy. It's fairly frustrating. So I'm going to try to sort of quickly, since we don't have time, to take you through many of the aspects of that. We've been interested in this disease for the last 2 decades, and I think that initially we collected about 200 patients of our own and published a lot of retrospective analysis. More recently, we had an opportunity to do a prospective study, the first of its kind in the United States and the world, and this is now has been published and continues to be published. So I think we have sort of have a fairly good understanding of the clinical manifestation of that, the outcome. We don't understand the etiology, but it is enough, I think, to be able to deal with this patient, prevent complication, and understand this disease. The first thing is the timing. Most of these patients present after the pregnancy. It's usually the first month, even more so the first week. A very common scenario, the patient goes home, patient has been symptomatic, everybody thinks this is a pregnancy, she goes home, continues to be symptomatic, getting worse, comes back to the hospital coughing, shortness of breath, and being labeled from asthma to pneumonia to anxiety to PE, but somehow peripartum cardiomyopathy is the last thing that people think about. Once they call the cardiologist, then it's a very easy diagnosis to make, right? You just put the probe on the chest, it takes you 15 seconds, and you see the ventricle not moving, and that's basically what it is. Now, the second part of that is that it is not always after the delivery, and some of the patients will come actually early. We just delivered last night a patient who came in 35 weeks, and she came in with peripartum cardiomyopathy. She happened to have preeclampsia, so they attributed everything to the preeclampsia, which is another problem. But she had LV dysfunction, systolic dysfunction, and I'll talk a little bit more about that. So the message here is patient can come at any time. Patient in pregnancy with heart failure, consider peripartum cardiomyopathy. This is the new definition now, including all the information that I've just described to you. And we say this is an idiopathic cardiomyopathy presenting with heart failure secondary to LV systolic dysfunction towards the end of pregnancy or in the months following delivery. Tuesday, I saw in the clinic a patient I didn't know from before with a diagnosis of peripartum, and she developed that 6 months after the delivery. So it doesn't have to be 5 months, and every time you have a situation like this, include peripartum cardiomyopathy in differential diagnosis. This is a study which shows, one, the incidence in the United States It's approximately 1 in 3,000. I see it here in a very small version of that. Okay, I see the two slides. So this is the study coming from North Carolina, about 250,000 live birth, and you can see that the the incidence was 1 in 3,000. But if you're looking at the ethnic background, then it is much less common in the white Caucasian. It is much more common, about 1 in 1,000, in the African American. And then you can see that there is actually a relationship to the age. So the older patients are more likely to actually develop the condition. We have seen, young girls, 14, 16, pregnant, developing peripartum cardiomyopathy. So you're not going to exclude the diagnosis in somebody who is young, but that's much more common in older women. And the really very important association is the preeclampsia. And the reason that I say that, in the past there have been a school of thought that if you have preeclampsia, this patient is excluded because the peripartum cardiomyopathy is a diagnosis by exclusion. You should not have any some kind of a condition that can actually cause heart failure. So there is a confusion about that. You see here that 29% of the patient had some kind of hypertensive condition, majority of them preeclampsia. The second association, very strong, is multi-fetal gestation. 9% in the normal population is about 3%. Characteristically, the ejection fraction is reduced to about 30%, but you can see here that the patient who died had an ejection fraction of 18%. So this is the patient population that you want to focus on in terms of complication. So please remember, this is the association: maternal age over 30, African American, twin pregnancies, history of hypertension / preeclampsia, and maybe multi-parity. So an important rule: preeclampsia presenting with heart failure, think peripartum cardiomyopathy. Preeclampsia plus left ventricular systolic dysfunction equal peripartum cardiomyopathy, because the pulmonary edema that you see in preeclampsia, and the patient I described to you yesterday, patient came in and the patient had, proteinuria and high blood pressure, and the patient had heart failure. So they presented to me like preeclampsia, complicated, but all of these, and pulmonary edema, which is an indication to deliver immediately. But here, the heart failure was due to peripartum cardiomyopathy because the ejection fraction was 35%. And this patient, I could have carried the patient much longer if the obstetrician would say, we are okay with the preeclampsia, because they were really not defining the preeclampsia in a classic pattern. So this thing actually, basically, there's a gray zone, and the confusion with preeclampsia is important because it can help you if you understand the difference and the actually association. It can help you to make the right decision. What is the clinical presentation? The patient presents with heart failure. They also have a much higher incidence of thromboembolism, and because of that we insist on anticoagulation, and sudden death is part of this phenomenon. Just to show you here that in a collection of 182 patients, 60% of the patients actually had delayed diagnosis of more than 1 week from the onset of symptoms. The patient developed symptoms, they went, either did or did not go to see a physician, and the diagnosis was made late. This resulted in complication that preceded the diagnosis in 50% of the patients. So many of them were diagnosed after the development of complication. CVA, pulmonary embolism, embolization into the limb, actually necessitating amputation. A lot of basically cardiac arrest, respiratory arrest. So 32% of the patient with transplantation-free survival had residual brain damage because of respiratory arrest, CVA, and cardiac arrest resuscitated. Why do we miss this patient? We miss the patient because the patient with heart disease look very similar to the patient who is pregnant and has a lot of complaints that sound like heart disease. And there's a long list here of signs and symptoms that can really confuse you. And I've been doing it now for over 30 years, and sometimes I have very normal women who come to my office and say that they cannot walk from here there. They cannot lie on their back. They have to use 3 pillows. They have some edema. It's very, very difficult. So it was mentioned that a patient like this, physical exam, EKG, echocardiogram, and BNP will give me all the information that I need. So you need to utilize everything basically that you have in order to establish the situation. Otherwise, it's very difficult. The patient with peripartum cardiomyopathy who is complaining that she's gaining weight, then the doctor says, you have twins, it's expected, just drink a lot of grape juice. It was one of the patients that I had. So, you have to take the time. The threshold to do an echocardiogram should be relatively low. And the patient with symptoms of shortness of breath and so on and so forth need to be seen by somebody who really has a better understanding in terms of the relationship between the symptoms and an underlying disease. The good news and the bad news about this patient is that as sick as they are, and they present usually with ejection fraction of 30%, normally 60%, then you can see here, this is our retrospective analysis, that about half of the patient recovered. The rest of the patient either did not recover completely or they don't recover at all, and they can actually progress into worsening, and they may need some help in terms of devices and transplantation, or that they are going to become asymptomatic but with an ejection fraction which is very low, and eventually, as time goes on, may actually cause some complication, including sudden death, and also progression of the disease, and eventually they will need some help with devices. The IPAC study, Investigation of Pregnancy-Associated Cardiomyopathy, we just finished that, was done in this country, and you can see that the study actually was designed to look at the immune activation, because the NIH, is more likely to give you a large sum of money to look at something which sounds, very sophisticated, like inflammatory markers, rather than support a registry, And so we actually tricked them in a way, and we got the money, and we recruited 100 patients, and all I wanted to know is really if I can confirm all the retrospective analysis we have done with now prospective analysis. So we had 100 patients that were recruited, and you can see that complete recruitment was 2012. We had a 1-year follow-up, so we finished everything by 2013. And this was the first publication last year in JACC. Just to show you the patient population, this is the age, and I told you the majority of the patients actually somewhat older. The majority of the patient, New York Heart Association class 2, 3, and some 4. The blood pressure was okay. The ejection fraction was 35%. And because of the fact that it was a study, then the patients were treated actually well. You notice here that bromocriptine was given to 1% of the patient, one patient that was actually in my institution. So we'll talk a little bit about that. So the IPAC study confirmed what we found, but showed that the recovery is even better, and the recovery was 65% of the patient had recovery of more than 50%. 35% of the patient had either partial recovery, and 7% of the patient had no recovery with ejection fraction less than 35%. What does it mean? If you have ejection fraction less than 35%, you're going to get an ICD, and maybe even a CRT, which is a biventricular pacing, which is a big deal to have a device like this. But that's, one of the downside of this condition. In addition, you see here that 4% of the patient died. Remember, these are patients who are completely healthy, going into the pregnancy and coming out with the need to have devices, and 4% mortality. 1 out of 25 of these women actually died. Some of them have been tortured on the way to mortality by having left ventricular assist device or transplantation. So even this is a very contemporary group of patients that even with all the sophisticated treatment that we can offer today, some of these patients are not going to do well. So the recovery, as I told you, the majority of the patients recover, and the timing of recovery is very important. You can see here that it took 6 months for the majority of the patient to recover. This is very similar to a data that we published some time ago. And here, the Duke people had 55 patients, showing that the patients who improved actually improved within 2 months. So we didn't have this data in our study, but when we looked at the IPAC study, we did have 66 women enroll early. The ejection fraction was 35% at baseline, but at 2 months it was already 48%. So the majority of the patients recover fast. And if you have a patient that has not recovered after 2 months, it's not a good sign. Some of them will continue to recover, and some of them will take 2 years to recover. But really, the people who recover usually recover fast. The African American in this country, the phenotypic presentation is different. So it is something that we need to know for 2 reasons. 1, they present with more severe disease. 2, they don't recover, as early and as fast. And you can see here that the rate of recovery, 40% versus 60%, African American versus non-African American. And in the IPAC, exactly the same thing. In the IPAC, the ejection fraction at the beginning was lower. They never caught up. Never caught up. At 1 year, still a sizable number of patients actually had LV dysfunction. So again, what are the reasons? Is it genetic? Is it environmental? We don't know. But it's really similar to what we see in Africa, in Black Africa. Can we predict early recovery? So it really was important. And the reason for that is that, we have devices that can be life-saving, ICD especially. And you have a young woman who actually walks from the hospital with low ejection fraction, just had a baby. Everybody is very emotional, including the patient family and the physician, and everybody wants to protect the patient and put an ICD. But before you know, it takes 2 months and they have normal ventricle, so you haven't done them any favor. So it's really important to be able to predict who is going to recover early and especially who is not going to recover. So we have done that. We divided the patient into 3 groups: very severe LV dysfunction, medium severe LV dysfunction, and ejection fraction less than 30%. And we found that this is now the patient who did not recover. So if you have ejection fraction of 30%, the majority of the patient actually recover. This is the missing portion of this bar. And only 21% of the patient did not recover to 50%. Remember, they started at 30%, so we're close to 30%. The green is not recovering even to 30%. And this is the window of ICD, CRT, and all of that. So if you have very, very poor left ventricular function, between 10 and 20, then the majority of the patients don't recover. About 30% of them will never actually exceed 30%. And the rest of them, 63%, will not actually recover fully. Okay, but remember that you have a third of the patients who are not shown here. These are the patients who recovered. So at the end of the day, we came to the conclusion there is a strong relationship between the initial insult, but individually it's unpredictable. So that the physician has to really, what we're doing now, we're using life vest as a bridge to actually recovery. I'll talk about it in a second. So this is the ejection fraction in the IPAC study. On the left, you see the patients with ejection fraction higher than 30 or lower than 30 initially, and you see the difference. So again, ejection fraction, strong predictor. The ejection fraction over 30%, 86% of the patient recovered completely, and less than 30%, only a third of them recovered completely. Another thing is the size of the ventricle. So again, it basically implies that the initial insult represented by dilatation of the ventricle or decrease in systolic function is critical in terms of the likelihood of recovery. So the patients with large ventricles are less likely to recover. This is less than 6 centimeters, and this is more than 6 centimeters. But maybe the best actually index is a combination of the two. You see that 0% of 11 patients who had an ejection fraction less than 30% and left ventricular end diastolic diameter of more than 6 centimeters recovered. So nobody recovered if they had a combination of a large ventricle and a small ejection fraction. Some of these patients, by the way, will come with normal sized left ventricle and decreased ejection fraction. I'm going to I don't want to go over time because of that. I just want to say something about the bromocriptine. The bromocriptine issue is based on two actually very elegant animal preparation studies that showed that peripartum cardiomyopathy in these animals was caused by a form of prolactin. It's a short actually prolactin, 16 kD, that has apoptotic effect, damaging the myocardium and endothelium. The other study showed some imbalance between pro-angiogenic so pro and con. So the actually substances in the body that basically encourage angiogenesis versus those who actually do the opposite. And this is actually a play that goes on in the placenta, initially in order to increase blood supply to the placenta, and towards the end of the pregnancy to try to decrease it in preparation to the delivery. So you have this imbalance between these substances that we see in preeclampsia too. So these two actually preparation showed that bromocriptine either completely prevents the cardiomyopathy or partially. And because of that, the clinical rationale was to use bromocriptine in patients with peripartum cardiomyopathy. And here you see, this is basically the data that everybody is basing the decision to use bromocriptine. In orange, the patient, this is the ejection fraction here on the vertical axis. All the patients receiving bromocriptine improved, and all the patients who did not improve. And in terms of mortality, the patients that received bromocriptine had 10% mortality, and those who did not actually had 40% mortality. So why is it that we are not jumping on basically and using this therapy in the United States? The reason is that we cannot actually apply this to the data that I've shown you from the IPAC. We had 4% mortality. Here you have 40% mortality. I show you the majority of the patient improved without bromocriptine. Have they show you nobody improved? So it's difficult really to relate to that, and we are planning on doing a randomized study, which is going to be very difficult to do in a population the majority of which improve. So how are you going and how many patients you need in order to do that? I'm going over time, and I'll just go to the end of that and just talk about the subsequent pregnancy. So the subsequent, I'll just summarize it for you. Okay, so this is the number one question that I get, and that basically initiated my interest in this condition, because I've been getting all this thing over the years. Can I become pregnant again? So the message is very, very, very simple. The patients who have consistent or persistent LV dysfunction have a much higher risk, including mortality. 50% actually will get worse. The patients who improve completely, 20% of them will get worse. Most of them will recover. Half of them will not. We haven't had any mortality, but we have some examples of really very, very life-threatening actually complication even in this patient. So although I think if you follow them prospectively, you can prevent most of the complication, they need to know that that this can result in ending up this process by an ejection fraction which is significantly lower than the ejection fraction they started with. So I'll stop here. Thank you very much for your attention.